আসসালামু আলাইকুম। আজকে আমাদের এই সুন্দর একটা সেশন, অর্থাৎ প্যান্ডেমিক জোন চলছে। আমাদের এই প্যান্ডেমিক যে সিচুয়েশন চলছে তার উপর পোস্ট কোভিড সিনড্রোম এবং পোস্ট কোভিড পরবর্তী যে ম্যানেজমেন্ট, এই গাইডলাইন নিয়ে আমাদের সাথে আছেন সুদূর আমেরিকা থেকে আমাদের চিকিৎসক সমাজের গর্ব ডাক্তার রুমি এ খান স্যার, অ্যাসোসিয়েট প্রফেসর ক্রিটিক্যাল কেয়ার অ্যান্ড ডিরেক্টর অফ কার্ডিও পালমোনারি ল্যাব, ইউনিভার্সিটি অফ সেন্ট্রাল ফ্লোরিডা কলেজ অফ মেডিসিন। দয়া অনুগ্রহপূর্বক আপনারা সবাই একদম শুরু থেকে শেষ পর্যন্ত আমরা যদি শুনি, ইনশাল্লাহ আমরা বেনিফিটেড হব। স্যার, নাও ক্যান ইউ স্টার্ট?
Good morning. Assalamu alaikum. I'm Rumi Khan. I'll talk about the post-acute sequelae of COVID-19 infection. Let's start my slides. Do you see my slide? আমার slide দেখা যাচ্ছে?
স্যার, দেখা যাচ্ছে স্যার।
I live in Orlando, Florida. I'm a pulmonary and critical care specialist here. I've been treating COVID patients since February, March. So post-acute sequelae of COVID-19. So it has many names. Now started with hashtag long COVID. People are calling long haulers. More clinical apt terms are post-acute COVID-19 syndrome or chronic COVID-19 syndrome. There is no clear agreed up definition, a work in progress regarding a definition. WHO will come up with a new update to their guideline that will have this post-acute or chronic COVID syndrome definition and management guideline. Here, for the sake of this talk, or most authorities, they are now defining as post-acute those who have a symptom extending beyond 3 weeks from the onset of symptoms. And chronic, those whose symptoms are extending beyond 12 weeks time from the symptom onset or from COVID infection. And to diagnose this post-acute COVID or chronic COVID syndrome, you don't have to have a confirmed COVID test positivity, because when it first started, in the first 6 months, most places, most people didn't have this testing availability. So in early group who will be in the chronic COVID time frame now, they did not have the test availability. Plus, in the initial first generation of COVID test, there are very high false negative, up to 35 to 40% were false negative. That's why a positive COVID test is not required to make a diagnosis of post-acute or chronic COVID syndrome. So let's step back. In Bangladesh, we know chikungunya. Chikungunya has ravaged our country a few summers ago. A couple of summer time, chikungunya was kind of endemic in Bangladesh. And many of you know the long-term, the lasting consequence sequelae of chikungunya. There have been a lot of papers coming out from different tropical countries about post-chikungunya syndrome, rheumatism, joint pain, all related to chikungunya. So this post-viral lasting syndrome, not related to specific site of infection, is not something that only related to COVID. We have seen that, we know, and work is progressing. And despite this, chikungunya is not new. COVID is a new infection, new virus that only 1 year old, but chikungunya is decades old. Still, we don't have clear understanding, a clear management guideline for this post-chikungunya syndrome. Then similarly, Ebola. Ebola is another virus. And there have been reports coming out that even people who recovered from Ebola, they also have experienced post-Ebola long-term unrelated to initial infection, post-viral symptoms. So a significant of the Ebola patient, they complaints of urinary frequency, headache, muscle pain, memory loss, joint pain, and they have chest finding, neurologic finding in many patients. And certain case uveitis, which does not go down, but other complications slowly over the time they improve. Their rate declines. So this has been explored. People have been trying to explain why this is happening. There have been defined school of thought. Some group saying it could be post-viral autoimmunity or some sort of immune fluctuations. There have been precedents of this perturbation of immune and inflammatory response to acute viral infections. It's not unheard of. As a give example of two cases in last two slides. The long-term sequelae happens as a result of autoimmune or inflammatory condition that can persist for years after Ebola virus or chikungunya virus. Even EBV, Epstein-Barr virus infectious mononucleosis, they have shown to cause this profound immune perturbation in the long term. And EBV has been linked to long-term complication into multiple sclerosis. So this immune fluctuation, immune dysfunction that is initiated by an acute viral infection is not new, is been seen and is still been explored. We are trying to explain it. So this first reports of post-acute COVID syndrome or chronic COVID or long haulers, or they call it long haulers or long COVID, is first came out in lay journal, popular journal. Then like in Science magazine, Stat magazine, in New York Times started seeing, and people start opening the social media support groups, Facebook group, different Twitter groups with the hashtag long COVID. These are first started. Then it gained traction. It gained traction because we know there's enormous global burden of this infection. There have been millions and millions of people are infected now. Even if a small proportion of those millions and millions infected people have this post-COVID or chronic COVID syndrome, then it will still be a big number of morbidity. The healthcare system will have to face. This is the opportunity for us. We are seeing it unfold in front of our eyes. So we need to know more, to have a more push to learn more. It is an opportunity to understand because of the sheer volume we are seeing. Also, research is happening in real time. And these are potential to lend insights to understanding persistent sequelae of other known and suspected viral infections. So this is as well as a problem burden, but as well as opportunity for us to learn long-term sequelae of acute viral infection. Nowadays, we are learning, we are hypothesizing that many disease conditions like chronic fatigue syndrome, as we just mentioned, multiple sclerosis, may be something that was started by acute viral infection, and these are maybe immune sequelae of a virus-mediated immune perturbation. So these are the papers we are seeing in last few months. JAMA paper, persistent symptoms of patient after acute COVID-19, viral journal, post-discharge symptoms and rehabilitation needs in survival of COVID-19 infection. The infection journal, post-discharge persistent symptom and health-related quality of life after hospitalization. The CDC has this study, the telephone study done. This is a study, small case series. They have 35% did not return back to usual health, 35% in a small trial they have done. And this is the UK trial from United Kingdom. 13% had some sort of symptom after 4 weeks. 4 to 5% had some sort of symptom after 8 weeks. And 2.5% had persistent symptom after 12 weeks. So they also showed that in the younger age group, 18 to 49-year-old group, it is 10%. Then rising to up to 22% in elder groups. And they have found one risk factor, that is high BMI, and women. Younger women is 50% more likely to have symptoms, especially younger women with high BMI has more likely to have it compared to younger men. And this is the CDC study. You see that's the one. It defines symptom. The blue shade is with persistence into headache, persist, body ache persist, fever, chill, much less, loss of taste persist. So this is the weeks and how long they are persisting, nausea, sore throat, chest pain, what proportion of them are persisting in male and female. So there are many of them even unresolved as of the interview date. So this is being reported in multiple ways. So if we try to classify it, try to group it as acute, post-acute, and later chronic sequelae, acute, as we know, that acute viral replication and initial host response. The symptoms are caused by acute viral replication and host response. And those are presented by fever, cough, dyspnea, myalgia, headache, sore throat, diarrhea, nausea, vomiting, anosmia, aguasia, dysgeusia, abdominal pain. At that point, you have a viral test positive. You may have antibody test positive after a couple of weeks. In the post-acute hyperinflammatory illness, those are happening as a result of dysregulated host response. The acute one happens as a result of viral replication, viral cytopathy, initial host response. The post-acute happens as a result of adaptive led or dysregulated, uncontrolled, abnormal host response. This post-acute hyperinflammatory illness include GI symptoms, cardiovascular symptoms, dermatological, mucocutaneous symptoms, skin rashes, respiratory symptoms, some neurological symptoms, musculoskeletal symptoms. And the time viral test may not be positive, but antibody test should be positive. And chronic, it correlates sequelae. Pathophysical pathway, and let pathophysical pathway proposed to, and we don't yet know, but we'll try to discuss what is the thought process. At that point, we see cardiovascular, pulmonary, neurological symptoms. Some psychological issues are there also. Post-acute pulmonary complication, we'll go in detail, but that includes studies suggest low diffusion capacity in the lung function test, reduced respiratory muscle strength, lung fibrosis that looks like IPF, cardiac complication, myocarditis, cardiac inflammation, thrombosis, and arrhythmias. Then we can see neurological complications, headache, anosmia, aguasia, stroke, seizure, encephalitis, mood swing, brain fog, concern for longer-term neuropsychiatric and cognitive deficits. Emotional well-being, concern for general distress, feeling of isolation and loneliness, stigma, risk of depression, PTSD, anxiety, stress disorder, substance use disorder, is all part of emotional well-being. If I recap the extrapulmonary manifestation, in the skin you can see skin petechiae, we can see livedo reticularis, you can see erythematous rashes, urticaria, vesicles, panio-like lesions. On the cardiac side, we can see Takotsubo, we can see myocardial injury, myocarditis, cardiac arrhythmias, cardiogenic shock, myocardial ischemia, acute cardiopulmonary from PE. Endocrine side, we can see hyperglycemia, diabetic ketoacidosis. GI side, we can see diarrhea, nausea, abdominal pain, anorexia. In the renal side, we all know kidney injury, proteinuria, hematuria. On the hepatic side, elevated AST, ALT, thromboembolism, and also neurological headache, dizziness, different sort of Guillain-Barré, stroke, anosmia. These are all acute, but all of them can persist, can happen in the post-acute chronic phase. That's why I am repeating it here. These are all acute, but all of them can happen in post-acute and chronic phases or late phases of post-COVID syndrome. One thing about long haulers, these symptoms, unlike acute, waxing, waning, the fatigue common, the paresthesia common, this neurological, cognitive impairment common, dyspnea, palpitation. These symptoms, this waxing, waning, This we differentiate them from acute. One other thing we need to remember, patients who are with COVID, they're very sick. They are in the ICU on vent, prone, on steroid long time. Some of them symptoms can be post-ICU syndrome, some physical handicap, functional loss, psychological PTSD-like issues, cognitive issues, all could be post-ICU syndrome. Post-ICU syndrome, sometimes difficult to differentiate from biological immunologic sequelae of SARS-CoV-2. So we need to know post-ICU syndrome and try to differentiate from this biological immunological sequelae of post-COVID infection. So as you say that post-sepsis syndrome or post-ICU syndrome, post-sepsis syndrome is characterized by, it is known, it had been even reported 2018 before COVID came in. Muscle weakness, fatigue, difficulty swallowing, brain fog, cloudy thinking, difficulty concentration, poor memory, difficult sleeping, sadness, anxiety. These all, this is 2018 paper, but all we are seeing also in post-COVID syndrome. So that's why sometimes people are thinking that all could be post-ICU syndrome. We are thinking as post-COVID. Probably a little bit more wise way to tell that, rather than completely shutting off the post-COVID syndrome as a post-ICU syndrome, because many of them having syndrome who even have not been in the hospital. They have a mild disease they're having. So it could be two defined entities. One is post-ICU syndrome phenotype, patient who had a long hospital stay on the vent and ARDS. And one is long COVID or post-COVID acute syndrome or chronic post-COVID syndrome. Those are happening after non-severe illness. They don't have this acute ICU stay or they don't have the vent dependence. So a little bit about post-ICU syndrome so that we can help us differentiate between these two. It means new or worsening impairment in physical strength. We call it ICU-associated ICU acute neuromuscular weakness. In the past, we used to call them called critical illness polyneuropathy. Also, they may have cognitive thinking or judgment dysfunction. They may have some mental health issues. All this happening after critical illness and persistent beyond discharge from the ICU or acute care setting. This is the post-intensive care syndrome. The treatment is, there's no single medication to fix it. It's a multidisciplinary approach to standardize assessment and targeted rehabilitation intervention during and after hospitalization. There is a recent consensus conference on prediction of identification of long-term complete impairment of critical illness at 3 to 12 months. So this is a big number of people, they experience some sort of symptoms post-ICU we mentioned just now. So we need to understand, is it a post-ICU syndrome or is it a long hauler happening after mild COVID infection? And pathophysiological changes may be from direct viral infection of different organs, different nerves, neurological, parenchymal infrastructure. It could be related to dysfunctional or fluctuating or unexplained immune response. It could be post-infectious functional limitation due to critical illness, post-ICU syndrome. So it could be self-limiting, it could be subacute, it could be chronic. That is the whole thing. So post-COVID syndrome, let me recap, it could be subacute, it could be chronic, it could be a simple post-ICU syndrome or post-sepsis syndrome. This is the post-ICU syndrome phenotype. It could be post-COVID syndrome, either immunological, neurological complication. This happens after mild inflammation, mild COVID infection. So you cannot blame it everything on post-ICU syndrome. So pathogenesis still being explored, still being discussed, still being studied. So is a very, the whole immunology of COVID still in a flux. A lot of new people. I'll not go in too much detail about pathogenesis, But one explanation is that the intense naive-driven effector extrafollicular B-cell response to severe COVID-19. The extrafollicular B-cell response to severe COVID-19, these are the people who have a poor outcome despite high titer of antibody. And sometimes they may have this lupus-like COVID-19 response that elevate, that induce defined sort of auto-antibodies in severe disease. They have serum ANA positive, rheumatoid factor autoimmunity positive in high titer. You can see lupus-like chronic post-COVID syndromes. We still don't know the real pathogenic role of autoantibodies in COVID disease. We are still thinking we are seeing the high, but they may be high for many reasons. So we don't know whether the autoantibodies are the reason for the symptom we are seeing. Also, we don't understand the prognostic significance of autoantibodies in post-COVID manifestations. Do they mean the symptom will persistent? Do they mean symptom will become very robust? Do they mean symptoms will be involve other organs also? So these are something is antibodies is one of the thought process as we discussed earlier. But we still don't know much about the more detailed, more information about the role of autoantibodies. So a bit about post-COVID cardiovascular syndrome. Some symptoms reported in post-acute COVID-19 period may have a variety of cardiac causes. We don't know the exact prevalence, exact cause. We can suspect, we can hypothesize. Some small cardiac MRI studies suggest post-acute setting very high incidence. A long-term cardiac effect, acute COVID-19 cardiac MRIs are not yet known. Autopsy has shown viral infiltration in the myocardial tissues, some viral replication, troponin elevation in acute phase are common, have multiple potential etiologies associated with comorbidities and poor short-term outcomes. Thrombotic complications common, especially in the ICUs. Microvascular endothelial damage are well documented, and some people, that is the main cause of most cardiovascular abnormality. And we see that echocardiogram are abnormal post-COVID. Even those people who had a normal echo before COVID, after COVID, they are seeing some abnormal echocardiogram and still don't have exact explanation, except microvascular endothelial damage, microthrombosis, and some suspected or presumed myocarditis from virus. Post-COVID pulmonary syndrome, lungs are probably the most common, are the most prevalent, and probably at the root cause of many of the post-COVID or chronic or late or long haul symptoms. Is the tip of the iceberg. The symptoms we are seeing, but we are not seeing underlying damage. Patients hypoxemic. Those who have pulmonary involvement, their big portion require ICU care. Big portion require mechanical ventilation. They develop ARDS. And ARDS changes the paradigm. ARDS changes the whole post-COVID scenario. It makes them, bring them whole different group of people who are recovering from ARDS than who are not recovering from ARDS. Cough and dyspnea is common post-acute pulmonary syndrome. We have a meta-analysis of 148 early studies involving 24,000 adults. They had this cough, fatigue, hyposmia, dyspnea in big number of patients. And again, another study from Curve published in Annals, and they have seen that during acute COVID and post-COVID, fatigue, dyspnea, joint pain, chest pain, cough, they all persisted. Rhinitis, red eyes, dysageusia, headache, sputum production, lack of appetite, they all persistent. We have seen a lot of patients with prolonged persistent hypoxia, oxygen dependence, prolonged respiratory failure. Question is that does this do they get better? Do they resolve? Is COVID-19 pneumonia recovery, resolution, and their clinical history is different from other pneumonias we see. We don't have a clear answer, but we are seeing a persistence of hypoxemia in many patients. We see this in a much shorter timeline in PJP or other viral pneumonia, but this COVID, we are seeing a very exaggerated, persistent of severe hypoxemia in many people who have ARDS or lung fibrosis. Also, we still are trying to learn what impact does COVID-19 pneumonia cause to people already who has chronic lung disease like COPD, lung fibrosis. Again, we don't know whether post-respiratory result. We still have to know. Probably one more study, if you do a lecture in 6 months' time, we'll have more data to tell whether how quickly they get it better or not. Many people are going home with oxygen. They're oxygen dependent. They're in hospital, stuck in the hospital because of oxygen need. A question how they will do, how they are doing. A big study probably involving those people, 6 months' time, we will know the answer. And this small study, our studies showed that COVID pneumonia-related hypoxemia, ICU oxygen need are much longer than influenza pneumonia. We already know that. It has been proven. And also we have known that we see that in the spirometry, we see mid-airflow obstruction. We see lung capacity reduction in people who have been to COVID-related hospitalization. We have seen the reduction in diffusion capacity compared to less sick people. The patient has a ground glass opacity, but eventually ground glass opacity improve in almost 91% of the patients. You see the ground glass opacity in the scan. 89% of critically ill patient had ground glass opacity. 86% severe disease has ground glass opacity. So ground glass opacity is very common. But the more severe the disease, the more we see bronchiectasis and fibrotic bands. 50% of severe disease has fibrosis, whereas 25%, 70% is severe and moderate disease has fibrosis. So the fibrosis is very common in more critical disease, but ground glass opacity is kind of equal across the board. Doesn't matter how critical or how moderate disease. Ground glass opacity is common irrespective of disease severity. But fibrosis is more common in more critically ill patients. This is ground glass opacity, and this is 3-month follow-up. Ground glass opacity almost resolved. And again, the subjective dyspnea, subjective impairment, the more critical the disease is, the dyspnea is higher. So a lung involvement, the more critical disease, the more post-COVID respiratory symptoms. Let me skip the slides. So let me move on to a little bit some post-acute rheumatological consideration. We know that multi-system inflammatory syndrome of adults, we are seeing that after COVID. We are seeing antiphospholipid antibody syndromes after COVID. We are seeing evidence of vasculitis condition after COVID. We are seeing prolonged fatigue, malaise, myalgia, arthralgia, often with a positive ANA. We'll see prolonged lymphopenia. We're seeing autoantibody positivity after COVID. These are all multiple rheumatological spectrum, still unclear etiology, still of unclear clinical or long-term significance. But we are seeing that. Post-COVID fatigue, malaise, myalgia, arthralgia, almost 36% has one of those symptoms. Some people develop long-term fatigue, chronic fatigue syndrome after COVID-19. These fibromyalgia that develop after COVID-19 are characterized by profound exertion, trouble thinking, remembering, brain fog, myalgia, arthralgia, headache, shortness of breath, chest wall pain, and more. Some also have positive ANA, and they have lingering lymphopenia. Lymphopenia is very common post-acute rheumatological condition after COVID, persistent lingering lymphopenia. So prolonged lymphopenia is found in 70% of post-COVID patients. Lymphocyte count is inversely associated with increased disease severity in COVID-19. Patients who died from COVID-19 have significantly lower lymphocyte count than survivors. Predominantly a T-cell lymphopenia, we see T-cell low. A mechanism is still unknown, but multiple proposed etiologies like T-cell death, a direct involvement of T-cell, all can be has been described, but nothing has yet been proven. Autoantibodies, we are seeing autoantibodies. We are seeing a different auto row, and now we are seeing anti-cardiolipin, ANA. We are seeing anti-interferon in different disease spectrum. We still don't have clear answer why we are seeing and what is the implication of that. So even children are not exempt from this post-COVID syndrome. This is a New York Times report about a 12-year-old girl. She's a COVID long hauler. So even children may have it. And children, we are seeing orthostatic intolerances, stand-up dizziness, immobility, joint hypermobility. We are seeing that. We are seeing neurodynamic abnormalities. But children's symptoms may not be consistent with chronic fatigue syndrome or genic encephalitis syndromes. So the care, how to manage this patient, how to treat them. Care for post-acute COVID requires an integrated, multidisciplinary approach. One doctor, one group of physicians, one pill, that's not the answer. First thing, there are a lot of psychological, cognitive, emotional issues involved. It needs a holistic approach with symptom, functional limitation assessment. We need to use some standard scale of dyspnea and disability scale. We need to do some kind of pulmonary function test, 6-meter walk test, oxygen scan, CT scan of the lung to see lung fibrosis. It has to be multidisciplinary care, involve self-care, patient self-care, primary care physician, with mental health service, clinical psychologists. Sometimes pulmonology, neurologists, cardiologists need to be involved for specific cardiac, pulmonary, or neurological complication. Rehabilitation, physical therapy, rehab, extremely important component of post-COVID management. And we still don't know much. So we are seeing post-COVID patients, you need to start collecting data, collecting all the responses. And we need more research. We don't have enough information to make a well-informed treatment recommendation. So the best approach, prevent. So don't get COVID. That is easier saying than doing. For the COVID-19 patient group, routinely assess for their mobility, functional capacity, swallowing capacity, cognitive impairment, mental health concern, and based on their assessment, determine the discharge readiness, rehabilitation, and follow-up requirement. Patients that are in or have been discharged from intensive care, those who need help. Older people need more help. Those who have suffered severe cases. Patients that exhibit signs of any of these impairments, and they need help. We need rehabilitation needs. What kind of rehab patient need? Patient need walking help, eating, drinking help. It need to be home-based, community-based rehab. Rehab is super important, physical therapy. So this is one experience. This is the San Francisco General Hospital. They have made a outpatients post-COVID clinic with involvement from pulmonary doctors, nursing, health, respiratory therapy, psychiatry, physical therapy, occupational therapy, neurology, and cardiology. These group of people, they have collectively, they formed a post-COVID outpatient clinic. Those see patients from home coming to deal with the post-COVID lingering symptoms. And this is how the San Francisco General, they structured their clinic. First, they do screening, take a referral. A nurse checks in 2 weeks' time. They check oxygen, they check medication, they schedule the visit. In 1 month following discharge, patient get a clinic visit. They do 6-meter walk test, see how far patient can walk, do oxygen level and walking. They do different sort of mental health questionnaire, functional questionnaire, memory test. They do social history, physical exam, and they did team discussion. There are 3-month clinic visits, like we do spirometry, DLCO at 3 months. We do targeted follow-up, functional, mental health, mental referrals. At 6 months, we do imaging and other studies like CT scan to whether scan getting better or not. At 6-month point, you send patient back to primary care. That's how San Francisco General structured their post-COVID clinic, syndrome clinic. So while management is just opinion, we don't have any research, we don't have any evidence-based randomized clinical trial to say this drug works, this drug doesn't work. This is based on a British primary care physician group recommendation. A patient symptoms 3 or more weeks after COVID syndrome. You take a full history, and you do you check for current symptoms. You examine their temperature, heart rate, blood pressure, respiratory exam, functional status by questionnaire, pulse oximetry, and do clinical testing. Then assess comorbidities and social financial circumstances. Then you manage comorbidities like diabetes, hypertension, kidney disease, lung disease. Then you do certain blood tests if you need to, complete blood count, electrolytes, LFTs, troponins, C-reactive proteins, creatine kinase, D-dimer, BNP, ferritin, X-ray, urine test, echo, EKG. They will help you triage your patient, which specialist patient need to be seen. Then patient, you can do symptomatic treatment, fever, paracetamol, you can use as needed, optimize long-term condition like COPD, asthma control, empathy, listening. Sometimes simple listening and empathy, just talking to help patient immensely. Many of them need psychiatric help, mental health support. If you think of secondary infection, high white count, consider antibiotics. Check daily pulse oximetry in patients who are short of breath. In general health, diet, sleep, smoking, sedation, self-practice, exercise, walking. Those who have fatigue, exertion, graded. Don't push hard too much, step by step. Today, a patient can walk for 9 minutes, tomorrow 12 minutes. Following definite, have them walking. Slowly increase the walking distance. Then set a target, and tomorrow I'll do more. So we put them into some community support groups, social groups, and continue to care. So this is the whole diverse approach. And sometimes I do, this is just supportive care. For chronic cough, I also try to make sure patient doesn't have any acid reflux, silent acid reflux. Try some PPI for a month. Sometimes post-viral cough, they need inhaled corticosteroid. Sometimes persistent cough may be helped by codeine. Sometimes breathlessness, exercise, swimming. Sometimes even very low dose opioid, low dose morphine can help severe breathlessness. Hypoxemia, oxygen, and graded exercise improve your deconditioning. Swimming again, fatigue, exercise, good exercise. Sometimes patient persistent hypoxemia, persistent breathlessness, and scan showing persistent ground glass. Ground glass means inflammation, unless there is a fluid overload. In that case, I have tried without any evidence yet, low dose long-term steroid, a decadron 1 milligram a day, then taper over 2, 3, 4, 5 months. Sometimes we can try that, still not, it is still under work, under research, not evidence-based. It just been workup, ventricular echo, cardiac workup, tachycardia. You need to make sure patient is not having cardiac inflammation. Echo and MRI will be helpful. So that's pretty much it. So you can contact me in my Twitter handle. And thank you very much. I'm open to questions now.
স্যার আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম সালাম।
স্যার আমার একটা কোশ্চেন ছিল স্যার, প্লিজ শর্ট টেল অ্যাবাউট ভ্যাকসিনেশন ইন Pfizer কোম্পানি যে ভ্যাকসিনেশনটা স্যার এইগুলো
at this point we have in USA we have one approved vaccine, even in USA, in Europe the BioNTech vaccine, that's a Pfizer vaccine, just got approved in US and UK. The second vaccine will be approved this week, this Friday, hopefully. These are mRNA vaccines. These are highly effective vaccine. And so far, based on between 40,000 on Pfizer side, 30,000 patients on mRNA Moderna side, 7,000 people study has been completed. So far, no serious complication, no serious adverse effect. And efficacy, effectiveness is about 95%. So very highly effective, very high. You cannot do any better than this by any vaccine. And if you look at the evidence, if you vaccinate 119 people in this way, you prevent one infection. So these are very good numbers for vaccine point of view. These are very high and very advanced vaccine technology. This has never been tried before. The vaccine we are developing now mRNA-based vaccine from Moderna and Pfizer, this group have been working on making vaccine for Nipah virus. That in Bangladesh, we have Nipah virus infection. They have been working on Nipah virus a vaccine. And when the COVID came, they stopped working on Nipah virus vaccine. And they put the same technology to develop this COVID-19 vaccine. This virus has a S protein, spike protein on the virus. The virus wall is covered by small spikes. These spikes is the way virus attaches to our cells. Without the spike, virus will not be able to attach to our cell, cannot enter the cell, virus cannot do any harm to us. So this spike protein is unique to virus. Whether virus mutates, whatever it does, but spike protein remains intact. It doesn't mutate. So spike protein is the way virus attaches to our cells. So what mRNA vaccine does, they put mRNA signal of the spike protein. So mRNA goes in the cell, start making spike proteins, only spike, not the virus. Spike protein get released from the cells to outside cells. Our body develops immunity against the spike protein. So when virus attacks you, then our body's immune system knows, already trained against the spike protein. So virus attack the spike protein. As a result, the virus itself gets killed. So it's a safe virus, it's an effective virus. It started being injected in America in this week, in England last week. And these two, Pfizer got approved, Moderna mRNA vaccine will be approved this week. I think 2 more vaccines will be approved next month. Those are Oxford, Chadox, there's a vector-based vaccine, and Johnson & Johnson protein-based vaccine. Those two will be coming within a month or 2. So I think there's a global WHO project called COVAX. They have made a plan way ahead 1 year ago. They already paid the purchase from different companies that not only reach Western countries, every country in the world, they will give vaccine for 20% of the vulnerable population from that WHO COVAX program. So Bangladesh will get some vaccine from this COVAX program for 20% of the vulnerable population, hopefully by spring, early next year. Thank you.
আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম শরীফ।
স্যার অসংখ্য ধন্যবাদ স্যার চমৎকার একটি ক্লাস নেওয়ার জন্য। আর আমরা আসলে খুবই ভাগ্যবান যে আপনার ক্লাসটা পেয়েছি। স্যার আমিও চট্টগ্রাম মেডিকেল কলেজের, এবং আমরা সবসময় স্যার আপনাকে নিয়ে খুব আলোচনা করি যে ইউএসএতে চমৎকারভাবে আপনি চিকিৎসা দিয়ে যাচ্ছেন। স্যার আমার ছোট্ট যে একটা প্রশ্ন ছিল, স্যার আমাদের এখানে আমরা প্রোফাইলেক্টিক হিসেবে ধরেন এই কোভিড এর সিমটম পাওয়া গেলেও অনেক সময় দেখা গেছে আমরা টেস্টও করতেছি না, কিন্তু স্টেরয়েড দিয়ে দিচ্ছি, বা আমাদের অনেকেই প্র্যাকটিস করতেছে যারা প্র্যাকটিশনার হিসেবে কাজ করতেছে, মানে স্টেরয়েড দিয়ে দিচ্ছে, পাশাপাশি ডক্সিসাইক্লিনও, এবং এখনো এটার প্র্যাকটিস চলতেছে। এই জিনিসটা আসলে মানে কতটুকু করাটা ঠিক হচ্ছে?
বাংলাদেশের লিস্টের ব্যাপারে আমি খুব উদ্বিগ্ন। বাংলাদেশে খুব ওভার ট্রিটমেন্ট হচ্ছে। কোভিড পজিটিভ হলেই কোনো চিকিৎসা করতে হবে না। কোভিড পজিটিভ হলে কোনো সিমটম
ছাড়াই দেখা যায় স্টেরয়েড শুরু হয়ে গেছে।
হ্যাঁ, এগুলো হচ্ছে শুধু স্টেরয়েড না, তো খুব হাই ডোজে হাইক্লেক্সেন দেওয়া হচ্ছে, অ্যান্টিকোয়াগুলেশন। এগুলো খুব রিস্কি। ইট ক্যান কজ ইন্ট্রাক্রেনিয়াল হেমোরেজ, ব্রেন হেমোরেজ। সিমটম ছাড়া, হাইপক্সিমিয়া ছাড়া স্টেরয়েড কাজ করে না। এবং যদি ব্লাড ক্লট, ডিভিটি বা পি কনফার্মেশন ছাড়া হাই ডোজে ক্লেক্সেন বা অ্যান্টিকোয়াগুলেশন দেওয়াটা হার্মফুল, কোনো নো নিড। নাম্বার 3 হচ্ছে গিয়ে পেশেন্টকে বিনা কারণে সবাইকে সিটি স্ক্যান করানো হচ্ছে। সিটি স্ক্যান করে কি লাভ? When you order a test, before you think, ask yourself, a test will it change my management based on the test? আমি কি আমার ট্রিটমেন্ট চেঞ্জ করবো? Will it make me do anything different than what I'm doing now? So don't do this scans. A CT scan has 70 to 180 times more radiation than X-ray. Unnecessary radiation exposure করার কোনো মানে হচ্ছে না। সবাইকে সিআরপি, ফেরেটিন এগুলো করে লাভ কি? Any viral infection, if you have flu, EBV, anything, those will be high. Any inflammation, this is a very non-specific test. সবাইকে সিআরপি, ফেরেটিন, রিডাইমার করানো হচ্ছে। Everybody. Those are not changing your management. You are treating based on your hypoxemia. If you have hypoxemia, give steroid. That's the only treatment available. A remdesivir, যদিও approve আছে remdesivir, if you are available, you can give remdesivir in patients who are having high fever, viral symptom early. But remdesivir data so far is not good. We are not getting.
স্যার বাংলাদেশে স্যার কয়েকদিন আগে একটা আমরা মানে আইসিডির সহযোগিতায় আমরা একটা দেখলাম, মানে পরিসংখ্যান দেখলাম যে মানে রেমডেসিভিরের কার্যকারিতা প্রমাণিত হয়েছে এরকম, যদিও স্যাম্পল সাইজ খুবই ছোট ছিল। স্যার এই ক্ষেত্রে মানে সম্ভবত 65 জন বা এরকম একটা স্যাম্পল সাইজ ছিল, তার উপর নির্ভর করে বলা হচ্ছে যে রেমডেসিভিরটা কার্যকরী। স্যার
অনেক বড় বড়
স্যাম্পল সাইজে কোনো কাজ মানে বাইরে হচ্ছে কিনা?
We have a very good trials on remdesivir. Solidarity trial came out, ACT trial. None of them showed any mortality benefit. Only ACT trial showed patient symptom improved earlier. Not a single study showed remdesivir improved mortality. So remdesivir also is not a great drug unless if you can give it very early in the disease within 3, 4, 5 days, high fever. You may make a case, a compassionate use of case, but it is not also that strongly evidence-based. So only thing that is evidence-based is decadron 6 milligram, dexamethasone 6 milligram in people who are hypoxemic. Their oxygen level below 94%. That's all. Or কোনো other ওষুধ লাগবে না. Anybody in the hospital should get DVT prophylaxis, that is Clexane 40 milligram once a day or 30 milligram once a day or something. But the dose they're using, the 60 milligram twice a day, full therapeutic dose, this is very dangerous unless you have a proof patient has a blood clot somewhere. It also only patients who are in the hospital.
আমার পরিচিত কয়েকটা কেস ছিল এরকম যে ওদের সিমটম আছে, মানে হালকা কাশি আছে, তারপর গলা ব্যথা আছে, কিন্তু কোভিড নেগেটিভ আসছে। এই ক্ষেত্রে কি স্যার আমরা কখনো ক্লেক্সনটাকে প্রোফাইলেক্টিভ হিসেবে ইউজ করব?
No. Patient severe illness in the hospital admitted. Only those people severe illness on oxygen level in hospital, bed bound, only ওদের জন্য। Nobody else. Clexane, rivaroxaban, এগুলো দেওয়া হচ্ছে কোনো কারণ ছাড়া at home, no need.
থ্যাংক ইউ স্যার। তার আরেকটা প্রশ্ন আপনি আলোচনা করছেন, সেটা হচ্ছে মানে এই কোভিড এর পেশেন্টদের ক্ষেত্রে আমরা যে সিটি স্ক্যানটা দিই বা এসআরসিটিটা দিয়ে দেওয়া হয়, তার এখন একটা প্র্যাকটিস খুব চলতেছে, মানে ধরেন কেউ কোভিড পজিটিভ ছিল পরে নেগেটিভ হয়েছে, মানে পোস্ট কোভিড সিন্ড্রোমের কথা যেটা বললেন। তো এই ক্ষেত্রে অনেক সময় অনেক মানে ডাক্তার বলছেন যে আপনারা একটা সিটি স্ক্যান করে রাখেন যে লাং ইনভলভমেন্টটা দেখার জন্য। মানে এখন উনি ভালো, হয়তো তখন একটু শ্বাসকষ্ট ছিল, মানে স্যার কোভিড থেকে উনি ভালো হয়ে যাওয়ার পরে সিটি মানে আগে সিমটম ছিল, এখন কোভিড থেকে ভালো হয়ে যাওয়ার পরে এই ক্ষেত্রে সিটি স্ক্যানটা করাটা কতটুকু মানে এক্সপোজারের রিস্কের তুলনায় এটা কতটুকু
দরকার নাই? But the question is that if you order a scan, you ask yourself, will this test make any change in my management? Patient doing better, আমি এখন কিছু করতেছি না, এই টেস্ট করে কোনো লাভ নাই। পেশেন্ট যদি সিমটম পারসিস্ট করে, হাইপক্সিমিয়া, শর্টনেস অফ ব্রেথ 3 months down the line, তখন যদি একটা স্ক্যান করে দেখা যায় যে whether patient has a fibrosis or not, even also that will not make a difference. But প্রত্যেকটা পেশেন্টকে সিমটম, অসিমপ্টমেটিক, সিরিয়াস, মাইল্ড সবাই স্ক্যান করানো হচ্ছে, এটা একদম কমপ্লিটলি উইথাউট এনি সাইন্স, উইথাউট এনি এভিডেন্স, উইথাউট এনি ইন্ডিকেশন, ইদার অল ওভার ডু করা হচ্ছে, ওভার ট্রিটমেন্ট, ওভার ডায়াগনোসিস, ওভার রিস্কি এক্সপোজার টু রেডিয়েশন থেরাপি, টু রেডিয়েশন।
জি স্যার, থ্যাংক ইউ স্যার আজকের চমৎকার ক্লাসটার জন্য এবং প্রশ্নোত্তর সেশনের জন্য। তার শেষে একটা ছোট্ট কোশ্চেন, যদি আপনার স্যার অনেক সময় আমরা নিয়ে নিয়েছি, স্যার দীর্ঘদিন যাবত আপনি মানে সোশ্যাল মিডিয়া এবং এই বিভিন্ন ইয়েতে লেখালেখি করছেন, বাংলাদেশের কোভিড পরিস্থিতি নিয়েও স্যার আপনি সবসময় উদ্বিগ্ন এবং লেখালেখি করছেন। স্যার এই ক্ষেত্রে আমার একটা জানার ছিল, সেটা হচ্ছে যেমন ইউএসএ তে স্যার গতকাল 3 লক্ষ মৃত্যু অতিক্রম করেছে, সে তুলনায় বাংলাদেশে যদিও ডাটাটা আমাদের হাতে ওভাবে নেই, কিন্তু মনে হচ্ছে যে মর্টালিটি রেট বা সিভিয়ারিটি একটু কম। এই ক্ষেত্রে আপনি এরকম কোনো আশঙ্কা করেন কিনা যে সামনের দিকে, মানে যে আশঙ্কাটা আপনারা অনেকদিন থেকে করে আসছেন যে বাংলাদেশে কোভিড পরিস্থিতি আরো খারাপ হয়ে মানে বাইরের দেশে যেরকম হচ্ছে উন্নত বিশ্বে সেরকম হতে পারে, এরকম কোনো আশঙ্কা স্যার করেন কিনা?
বাংলাদেশে কোভিড আরো খারাপ হচ্ছে, আমি ভয় পাচ্ছি it may get worse in next couple of weeks to month. আর নাম্বার 2, বাংলাদেশে মৃত্যুর হার যে কম, আমি এটা নিয়ে বলতে পারছি। বাংলাদেশে তো কোনো ডেথ রেকর্ড করা হচ্ছে না, কোনো টেস্ট রেকর্ড করা হচ্ছে না, কেউ জানে না কে মারা যান, গোপনে দাফন করে দিচ্ছে। সুতরাং ইট ইজ নট যে বাংলাদেশের স্টোরি আমরা জানি না, এখানে ইগনোরেন্স, প্লিজ। We're living in a blissful world of ignorance. When you don't know, you are happy, we are fine. But real picture is maybe much worse. Bangladesh, যদি কোনো study হয় how many extra people died in this year, we will know. But I doubt Bangladesh cannot be defined from India, cannot be defined from Brazil, cannot be defined from Sri Lanka. Bangladesh has to behave like other countries. So we are same human beings. Define Bangladesh, we don't have enough good data.
স্যার থ্যাংক ইউ স্যার। স্যার এই সর্বশেষ যে কোশ্চেনটা করবো স্যার, সেটা হচ্ছে যে ইউএসএ তে যেদিন 3 লক্ষ লোক মানে মৃত্যু অতিক্রম করলো, ওই দিনই কিন্তু ভ্যাকসিনেশনটা শুরু হলো। এই ক্ষেত্রে বাংলাদেশ সরকার বা সাম্প্রতিক অনেকে বিভিন্ন কথা বলছে যে জানুয়ারিতে আমরা পাবো বা পেতে দেরি হবে। স্যার এই ক্ষেত্রে আপনার কোনো অ্যাজাম্পশন আছে কিনা যে বাংলাদেশে ফ্রন্টলাইন হেলথ ওয়ার্কার থেকে শুরু করে সাধারণ জনগণ যারা আছে তারা কবে ভ্যাকসিনেশনের আওতায় আসতে পারে?
বাংলাদেশে তো গভর্নমেন্ট শুনলাম দে আর doing a contract with Serum Institute of India. ওই জানি না ওটা
স্যার মানে অক্সফোর্ড ভ্যাকসিনের সাথে,
ওটা কোনো অ্যাপ্রুভই হয়নি, ওটা কোনো অ্যাপ্রুভই হয় নাই, এটা কবে হয় যায় না। তবে সেপি এবং গাভি জিক্লো এবং ডব্লিউএইচও এটা কম্বাইন্ড প্রোগ্রাম। সেপি একটা বিরাট এনজিও, ওরা ভ্যাকসিন বানায় ফর থার্ড ওয়ার্ল্ড কান্ট্রিজ, GAVI গ্লোবাল ভ্যাকসিন অ্যালায়েন্স এবং WHO কোভ্যাক্স প্রোগ্রাম। They have made a commitment. Bangladesh is part of the commitment that every country in the world will get at least 20% vulnerable people will get vaccine as soon as it became available. The moment next month, I hope Pfizer or Moderna or other thing, they can supply them, Bangladesh will get some vaccine from them by next month or 2 from this Pfizer or Moderna or Johnson Johnson Novavax or Oxford vaccine from those WHO COVAX program. I'm not talking about Serum Institute Indian vaccine. ওইগুলা পাবে, কিন্তু পাওয়ার আগে আমাদের গভর্নমেন্টকে ভেরি ক্লিয়ার ট্রান্সপারেন্টলি একটা লিস্ট করতে হবে কারা প্রথমে পাবে। হেলথ কেয়ার ওয়ার্কার্স, এল্ডারলি পিপল, ভালনারেবল পিপল, সিক পিপল। বাংলাদেশে কখনো বাংলাদেশে অ্যাডাল্ট ভ্যাকসিনেশনের কোনো নাই, অ্যাডাল্ট ভ্যাকসিনেশনের কোনো এক্সপিরিয়েন্স নাই বাংলাদেশে। We are used to vaccinating children and at most pregnant women. In the adult, elderly people, mass vaccination কোনো history, কোনো experience, অভিজ্ঞতা কিছু নাই। বাংলাদেশ গভর্নমেন্ট থেকে একটা পাওয়ারফুল টাস্ক ফোর্স করে, পাওয়ারফুল কমিটি করে এখন থেকে এই ব্যাপারে কাজ করতে হবে। পরে ভ্যাকসিন আসলো, কিন্তু তখন আমরা প্রিপেয়ার্ড নাই, ভ্যাকসিন 1 মাস ধরে পড়ে থাকবে, ভ্যাকসিন নষ্ট হবে। সে কারণে এখন থেকে একটা পাওয়ারফুল কমিটি করে একটা ক্লিয়ার ট্রান্সপারেন্ট গাইডলাইন করতে হবে, কে প্রথমে, কে সেকেন্ড, কে থার্ড, কে ফোর্থ পাবে। এইটা কোনো বিকল্প নেই।
জি স্যার, থ্যাংক ইউ স্যার। আমরাও আশাবাদী যে সরকার সেটা করবে। স্যার শেষে আপনার প্রতি স্যার ছোট্ট একটা অনুরোধ, স্যার আজকের এই চমৎকার সেশনের জন্য আপনাকে ধন্যবাদ। এবং স্যার আমরা আপনাকে নিয়ে আরেকটা সেশন করতে চাচ্ছি। আপনি স্যার এই চট্টগ্রাম মেডিকেলে পড়েছেন, স্যার আমি চট্টগ্রাম মেডিকেলের 51তম ব্যাচের। স্যার আমরা আসলে আপনার জার্নিটা একটু জানতে চাই। চিটাগং মেডিকেল থেকে আপনি এখন ইউএসএ আছেন, এই জন্য পুরো জার্নিটা আপনার, এই জার্নিটা নিয়ে আমরা একটা সেশন করতে চাচ্ছি স্যার। মানে আপনার পুরো মেডিকেল জার্নি নিয়ে এবং ইউএসএ চিকিৎসা নিয়ে একটা গাইডলাইন নিয়ে।
Of
স্যার
course.
সেটার জন্য আমরা অপেক্ষায় থাকবো আপনার এই পরবর্তী
ইনশাআল্লাহ।
সপ্তাহে বা যে কোনো একটা সপ্তাহে আপনার ফ্রি সময় ইনশাআল্লাহ আমরা
হ্যাঁ,
নক দিব স্যার।
ইনশাআল্লাহ ইনশাআল্লাহ। থ্যাংক
থ্যাংক
ইউ
ইউ
সবাইকে,
স্যার।
সবাই ধন্যবাদ। আসসালামু আলাইকুম। হ্যাঁ, sure, হ্যাঁ।
আসসালামু আলাইকুম।